Hey, everybody. Welcome back to the You Are Not Broken podcast. I have my good friend, Dr. Carrie Cashell. Am I saying Cashell right, Australian-wise?
Absolutely. Yeah.
Okay,
Cashel.
Dr. Carrie Cashell. She likes to swear, but it's in a beautiful quasi-Australian accent. So welcome to the podcast.
Thank you for having me, Kelly. So
We're
nice
going to
to
talk
see
about
you
a bunch
again.
of different things. We're going to talk about the number one killer of Australians in 2026. We're going to talk about testosterone in Australia. We're going to talk about why so many Australians are on DHEA and Americans aren't. And what happens when your body says no thanks in midlife. Welcome. I'm so excited you're here.
Yeah, it's so nice to see you, actually chat to you
It's
again.
so good.
It's been too long.
How did we meet? For people who don't know, Dr. Cashell's like at least half of the reason, if not more than half the reason of how I got to Sydney in March of 2025. And now on Instagram, my number one city of followers is Melbourne.
Yeah, I think the Australians absolutely love you. So I was following you then in the Menopause chat group together on WhatsApp.
Okay, yep.
Lovely, that thing that I go in and just suddenly I'm an hour late for work.
We're both in the Menopause. Yep.
And then I think you might have said something about wanting to come to Australia and make it so.
Oh, did I manifest you?
Maybe. Yeah, I think you definitely have some role in, definitely igniting that idea. And then I started to look at a way to bring you to Australia. And of course, the only place to host such a fabulous lineup like yourself and Dr. Louise Newson and Dr. Marie Claire is in
Dr. Von der
Menopause.
Wright.
And Dr. Von der Wright and Professor Joshie Kulkarni.
Kulkarni was
Yes.
there.
So
This was
awesome.
So my favorite. Do tell me if you have a different favorite Sydney, Australia story. This is my favorite. It was an amazing trip. I got to pet a koala butt. It was fantastic. But the night of the Sydney Opera House event, it went off. It was fabulous. It was like such an iconic place and a wonderful event. We're in the car going to dinner the night of the event happened. And I'm poo-pooing the standing ovation that we got because I'm like, yes, people stand all the time because like we help them feel seen and it's a very important topic. And I'm kind of like, yeah. We get standing ovations like all the time. It's fine. And somebody said, Kelly, you don't understand. Australians don't stand. And the host, I'm going to blank on her name right now, but she's like, I've been
Shelley,
yeah. She's like, I've been emceeing in Sydney for 30 years and this is my third standing ovation.
Yeah. So it was huge. Yeah. The Australians are not like they're pretty out there. Like everything's pretty good, pretty exciting, but praise, yeah, you got to earn it. So to have 2,500 women stand up and applaud, yeah, that was something. I've never experienced anything like that in an Australian theatre before. That was
Here, the Americans
amazing,
are like,
immense.
yeah, we congratulate people for graduating kindergarten.
That's true. Yeah, that's true. Actually, I've watched your graduation ceremonies just for leaving school. No, it's not like that in Australia. Yeah, it's big.
Absolutely fantastic. What was your favorite part of that whole event? The whole of the whole week.
God, it was just, so I think just looking out at that audience when you guys were on the stage through the curtain and just seeing all these women just wrapped and just this palpable, joy. There was just such an amazing feeling. I think just being able to bring all those women together and know that each of those women was going to go and speak to another 100 women, like the ripple effect from an event like that is just mind blowing. So I think that was beautiful. I think the joy and the empowerment that you could palpate.
It's so good. I mean, and I like, it's so big and then it's so micro at the exact same time. Like you said, like there was a woman there who brought her mother, her older mother, and she's like, afterwards, she was like, Kelly, because of you, she finally agrees to go in and get vaginal estrogen. And it's like, that's what we do. Like, it's a big macro, like to change the culture on a macro level really does mean many, many individual lives are being changed.
Yeah. And I think, the things that were said on that stage are things that we all say day to day in our clinical practice. To say it to a group of women, not only are you delivering it to this much bigger group of women, this connection that is created when women are sitting together and supporting each other, it amplifies the message in ways that you can't really imagine. And that event gives so many women the confidence to go and speak to their doctor and say, I think there's more that we could do for how I'm feeling and how I'm going to be for the next 40 years.
I love it. I mean, Australia is unique worldwide because of the female dose testosterone product that you guys have for prescription. And how long have you guys had this? It's called Androfem. And how long have you guys had Androfem?
I think I actually haven't checked the dates. I think it's about nearly 10 years it's been
10
around.
years?
Yeah, I think it's been, and it was in Western Australia and not in the rest of Australia for a long time. We've been able to get it in, there's multiple states in Australia, 6 states, I think. And so we were able to get it into New South Wales from 2020. So I think that's when it went on to our TGA, which is the equivalent of the FDA in the States. And then, but still, so it's been there for a while. It's made in Australia, only country in the world, as you say, that makes it. It's licensed for the treatment of hypoactive sexual desire disorder in women, which is a very long way of saying distressing low libido. So you want to have sex. It's not that we're trying to make everybody want to have sex, but yet. And we think that probably affects about 1 million Australian women. So there's good data showing that about a third of women aged over 40 up to about 65 experience distressing low libido. So that's about 1 million Australian women. So it's a lot of women, and less than 15,000 get a testosterone
Yeah,
script.
I mean, that was shocking to me when I went over there and was talking to women of how I would use the word underutilized Androfem still is in a nation that's had it for years and years and years. The other big thing I heard a lot of Australian women is the doctors ask them if they're partnered. And if they're not partnered, they don't get access to testosterone. And to me, that's a big problem.
Yeah, I mean, libido, we can, if we're trying to stick to exactly the licensed indication, it is about sexual function. But you and I have had plenty of chats that libido is so much more than just a desire to have sex. It's just a desire to be alive and do stuff,
Mhm.
and I would say that and if you're single, even if we just stick to sexual desire, it's absolutely fine. If you just want to be able to enjoy sex by yourself, it can be a one person sport. It doesn't have to be two. So even if we just stick to sex, like women should be allowed to have pleasure by themselves. I actually love, that's one of the things I've got my little clitoris sitting on my desk now, and the conversations that I have with older women, when we're talking about gender urinary syndrome of the menopause or just sexual health, like that clitoris. And then suddenly I'm going, well, buy yourself a vibrator. You can buy your first vibrator aged 85. That's fine. Just go online. We've got small ones. We've got ones made by women. You've got
You have an
Lara from
amazing
Elixir.
Australian product made by women, Elixir
Mm,
Play. I'll
exactly.
plug them. They're very high end. They're very soft and comfortable to hold.
Yeah.
So
So
yeah,
my I
vibrators made by women.
and I love that. And I think that, yeah, my patients try. Like it's a Sydney woman, and she makes it. So you're supporting local business, and even if you don't want to buy a vibrator, it's good for female economy.
Totally. Yeah, are you surprised that doctors are requiring or asking women if they're partnered in order to give them testosterone?
Yeah, I would find that really offensive. It's something I have.
Do we ask men if they're partnered to give them Viagra? Is that ever asked?
No, and we don't ever ask them, as you've said before, like, does your wife want to have sex with you? Or would your wife like some vaginal estrogen if you want to have sex with your wife? And we don't have a page of whether you meet these criteria for this low libido for men, which we have, which HSDD is like a 20 question questionnaire to assess, are you distressed enough for long enough?
There was an insurance I know you guys don't have Addie flibanserin yet, but there's talk. But so we have that drug for HSDD in America, and an insurance company was requiring a woman to fail marriage therapy first before filling this prescription. And, we basically went off and we're like, do you require men to fail marriage therapy before you prescribe them Viagra? And if not, then don't do that for the woman.
Yeah, it's the gender bias, particularly in sexual health, is shocking. We have 9 testosterone products on the PBS for men, and we have none for women.
Yeah.
So we
So
have one
let's
that's
talk about that
approved.
because we're here to address something that could be exciting. Explain to the world, because we're not, sadly, not all Australians. But so your PBS is basically like America's Medicare.
Yeah,
So
so
it's
that's our cheap
basically
drug
like
scheme.
there's a list of medications that the government will cover.
Yeah, they come to an arrangement with the drug company, and then they cover the gap. And so a patient, if they get a PBS drug, the most they'll pay is $31, which is about $18 US a month.
Nice. So men have 9 testosterone products on your PBS. And although Australia has a female dose testosterone product, it's not covered by the PBS. So it's much more expensive,
Correct. Over $100 per tube.
over $100. Does anybody just give women the male dose? Does that
Yes.
happen in Australia?
Yeah, well, it doesn't happen a lot because if you look up how many testosterone, female testosterone prescriptions are used, there's not a lot of male testosterone products used for women. But yeah, we do for cost reasons.
Yeah, I would
So
say
we
for
can use
cost reasons.
testosterone. Yeah, but
So
it's
what are
not
you
as good.
So what are you doing right now that's timely in petitioning the PBS to cover testosterone? How's that going? What's the plan?
Yeah, so we've decided we would show that testosterone for women on the PBS actually matters to Australian women because there's, everybody's talking in their own groups and complaining about the cost, but that information has to get to the higher level so you can make the decision. So as a result of our menopause inquiry last year, the government waived the huge application fee that companies have to pay to apply to get onto the PBS with no guarantee that they're going to get on. So they waived that for the companies that make 2 of our body identical hormones, Estrogen and Prometrium, which is the estradiol gel and the micronized progesterone. So that
Nice.
got waived. So that was great. And they're now on our PBS. So our standard
Nice.
estrogen and progesterone HRT is now costs women on average about 16 Australian dollars a month, which is, 10 US dollars a month, which is awesome. And they also waived the fee for another big company who makes a couple of the combined oral contraceptive pills. So we know that they can do that. So we are petitioning the government to waive the fee because our androfen product is made by quite a small pharmaceutical company, and these fees are usually prohibitive. And that's why a lot of a lot of companies don't even apply. So we want the government to waive the fee, and then we want them to encourage the committee who makes the decision about what drugs get listed to really consider this as an important drug. So really using their discretionary influence and power to make the process, to make it happen, because they can. This is something they can actually do. The drug's made, the drug is licensed, it just needs to be affordable. So that's really, and that's something that the government can do. So we've petitioned, so we've sent this petition now, which is nearly 11,000 signatures, thanks to people like you sharing it.
Don't whisper. It's a podcast.
Thank you to
All
people
they
like
have
you
is
for
audio.
sharing. So thanks to people like Kelly for sharing it. And so the government now are interested. They know the petition exists. We're now lobbying local. We're getting people to lobby their local MPs to really add that political voice in Canberra, which is where our government sits, to say that this is a really great opportunity for Australia to be a world leader in sexual health equity. We would be the only country with testosterone product made for women, licensed for women, and affordable for women. So that would be, Australians are quite patriotic. They would like that.
Is Viagra, etc., on the PBS?
It is not. No, it is only cheap for our veterans. So it is still expensive for men, but it's not as expensive.
But testosterone's on the PBS for men.
Correct.
Yeah. So that would be gender equity issue.
Correct.
And we're going to put the link in the show notes. Can anybody sign this petition?
Well, I think if you feel that Australian women deserve it, I think you can sign.
Sign it? Okay,
absolutely.
Wonderful. I love that. Yeah, I actually saw the paperwork of the reason why New Zealand, and this is public, I'm allowed to say this. I saw the paperwork of why New Zealand turned down their PBS equivalent for covering testosterone, because now they have androfem as well. And one of their reasons is not everybody would want this product, so we're not going to cover this product. And I'm like, that's literally true of any medication. Like, should we not approve a seizure medication because not everybody's going to need treatment for seizure medications? Like, the reasons for turning it down are laughable when you can actually read it. You're like, are you effing with me?
Like, what other drugs? I mean, there's very few drugs that might help a third of the female population.
Yeah. Yeah.
It's basically hormones.
It'll be interesting to see when we get a testosterone in America, what it's going to be licensed for, because I think low libido is problematic. Number one, because doctors are freaking asking women if they're partnered as access to get this or not. And it's like sex is already so stigmatized that I think it's a bummer indication, even though, yes, it does help libido and we have studies for that. But it's like the softer things that are hard to measure, not that libido's not hard, But like one of the biggest, I always joke, like women don't come back and they're like, testosterone only helps me with libido. Like it's a brain neurochemical, helps with like the I feel more like myself is absolutely huge. You'll never get an indication for that, but it helps for more than just libido.
Yeah, I think we need to pursue, and that is exactly it. And it doesn't work for everybody for libido, and it doesn't work for everybody full stop. But for I would say it's a third of women, it's a game changer. A third of women, it's icing on the cake, and a third of women just go, nah. After 6 months, I am no different. But we do have, we have a randomized controlled trials showing that it improves verbal recall. So, and that's that word finding difficulty, and that's what probably the thing I notice the most for myself. And that's what women really complain about who've had surgical menopause. So I've presented at meetings where women have had their ovaries removed before the time of natural menopause. Some of them have managed to get estrogen and progesterone, not all of them, and none of them were on testosterone. And the one thing they all complained about was being able to find their words.
Yeah. What's the name for that one
Where's it gone?
thing? Yeah, like that thing.
Yeah.
Louise Newsom's clinic just published a paper looking at testosterone for mood, energy, being treated for like depression, right? Like it works in the brain. We have dementia studies for men.
Yep.
We don't have any for women that I've seen because it's just nobody
Too long.
thinks that testosterone's even in female bodies. But I'm like, brains are brains. And what struck me that when I was in Australia, I don't know where I was where I read this in Australia. And then I asked several people, like, is this true that in 2026, dementia is going to be the #1 killer of Australians?
I think it already is this year. It's surpassed heart disease. So no, it is already our main killer.
Jesus.
And there is data, and there is a study that shows for women at high risk of dementia, the ApoE4 carriers, that low testosterone is associated with increased rate of dementia.
Yeah. Same with estrogen for the ApoEs.
Yeah, so there's data there for low testosterone, and we've got data showing that low testosterone in women is associated with heart disease, it's associated with osteoporosis and an increased risk of dementia, and these are the main causes of death and disability in women. So I think we can do more research. We can measure bone density. That's another thing that is easy to do on testosterone.
Dude, when I was in Australia, we're like, we think it's so awful that our screening for osteoporosis in the US is 65. And then when I was in Australia and they're like, it's 70 here. And I'm like, good Lord. That's not, it's not, can you call it screening at that point? Or just diagnosing osteoporosis?
Well, what you've done is you've made sure you've diagnosed the osteopenia or the osteoporosis at a time when most doctors won't use hormone replacement therapy or MHT. So the only drug you're going to use is, the only drug most people will use is a specific osteoporosis drug. You have to wonder who decided on 70, 5 years after 65, when we have guidelines in Australia to use hormones for osteoporosis up to the age of 65.
Interesting. Very interesting. I mean, that's one of a big, talk about splitting hairs, first of all. But like in America, estrogen is FDA approved for the prevention of osteoporosis. So people kind of get all bunchy about yeah, but we can't use it to treat. And I'm like, but if you get a DEXA and it says your left hip has osteoporosis, why can't you protect the rest of your bones with estrogen? Nobody ever seems to think of that logic. And then number 2, in Australia and the UK, it's actually indicated for treatment of osteoporosis. And then people will be like, yeah, but the osteoporosis drugs work better. And I'm like, yeah, but we actually have data that says both of them together work better than either alone. So we're getting too focused on that we don't have an indication for it, instead of thinking estrogen will always have a benefit on bones.
I love, we've got a brilliant professor in Australia who is, her osteoporosis and menopause is her big area. And she describes estrogen as nature's gift to bones. And there just isn't something, I just love that. And it's true, and also because it's supporting everything around the bone. So our bone drugs work on our bones, but they're doing nothing for our tendons, our ligaments, our muscle, our hearts, our brains. But, so we've got the whole musculoskeletal systems benefiting from hormones, not just
totally. Dude, back up for a second and tell us how you got into menopause. Because you're basically I'll make her blush if I say one of the menopause gurus in Australia. Everybody goes to you. How'd that happen?
Testosterone.
Testosterone turned you into a menopause expert. Tell me everything.
Yeah.
That's a good story. I'm surprised I don't know it.
Yeah, so that's really why I am particularly passionate about the third female sex hormone, or maybe we should call it the first one, because it's the one that converts
In
to
my new
estrogen.
book, testosterone comes first.
I like it. Yeah,
Like I'm sick of estrogen being like, which we have less of than testosterone. I'm sick of it being the female hormone because it's technically incorrect.
exactly. It's just too shiny. Let's bring testosterone in, solid and supportive. Yeah, so about 4 years ago, a lovely patient came in. I've obviously not been arrogant and paternalistic enough, because she came in to ask me for testosterone, and I said, that's not a female hormone. Don't be ridiculous. And
So
she said, yes, it
you
is.
had androfem available in Australia. A woman came in asking for androfem, and you said no.
Yeah, I said, I have no idea how to prescribe it. And she said, well, I'm on it and it's absolutely amazing. It has changed my life and you need to know how to prescribe it so that you can change other women's lives. And she goes, and
She was like the fairy godmother.
she's my patient zero, and she's awesome, Jules. So she's a trained nurse, and like I work in a village, so I know everybody. So I'm connected to a lot of my patients. So I did the course that she told me about, which was by some random GP in the UK, Louise Newson or something. So yes, I did Louise's Confidence in the Menopause course, and actually listening to her podcast, my brain just exploded each time. I'd be like, oh my God, and I'd be going into work the next day and phoning 5 patients and saying, you don't need to be on all of these antipsychotics and antidepressants. And, really, and from that one interaction, I've just then been on this learning journey into menopause. So testosterone was the window. And I've always prescribed hormones. I had some pretty good education as a GP trainee. I had maybe 2 lectures or two tutorials on hormones. So yeah, I was very well educated, and compared to others, still shocking. But that really then changed. Just look at hormones as sort of the central to health, and then to use that as a framework. And then you can see how it impacts. I look after teenagers, I look after women in their 90s. So just really seeing it as a way of understanding how female health is different to male health. So yeah, and since then all I do is read menopause stuff. And then I started to lobby to try and I wanted to get progesterone onto the PBS. So as a result of making contact with people at that point, I got connected into our Australian menopause and got involved in the Senate inquiry and presented at that. And then, really tried to make some, for my bit, these are the things I think you guys can do. And I was really excited because actually the things I asked them to do, they did. I like to think that was me. There was hundreds of submissions, but they did some pretty cool stuff out of that. And they still haven't addressed some of the big things like really poor education in menopause. That's huge. And yeah, so since then, yeah, I've just connected. So Louise, and then I got Louise to come and present at a event in 2023, just locally. And that really made me think I could do these bigger things. And then we started our Healthy Hormones community, which is our online menopause community of clinicians in Australia. We have some Americans. Don't know if we have any Canadians. And we've got people from Europe. So we've got this community of clinicians all talking about menopause and what they do and how they think we could do it better. And we've got a community for the general public, for women who are struggling to access care and who are not sure what they should do when X, Y, and Z happens. So really trying to provide that reliable information, because there's so much misinformation out there.
Nice. So Healthy Hormones has two arms, basically, like a clinician
Yeah.
support arm and then a lay population support arm.
Correct, yeah.
Nice. Tell me so after the Sydney Opera House, the next day we did the menopause course? She ran us ragged, but we were there for it all. And that had 300 people at it?
Yeah, 300 people came, and I think 500
people online. This was in Sydney. The best thing about it is, compared to an American conference, you guys actually had like nice espresso makers. Like I literally probably had 3 cappuccinos.
No, that was key. That was the thing that we spent the most time organizing, was making sure there was decent coffee and decent food. Emma, my partner, Emma Harvey, is very passionate about good coffee and good food. She didn't care if you guys didn't do any good education.
A step above an American conference as far as the coffee goes. And in Australia, they don't F around with paper cups for coffee. You have coffee in a nice mug with a saucer. And it's very fancy feeling, and I'm obsessed about it.
But it was great. Yeah, that conference was amazing. We had the feedback
What was
phenomenal.
Your takeaway, like, after it happened? Were people happy with it? Do they want more? Like, what how did you guys feel when that conference was done?
Well, apart from overwhelming relief, because we were broken after several days of events, yeah, just like, when can we do this again? Because people just said, that's the kind of conference I want to go to. Like, we weren't being talked down to, even just the setup, the way we had the stage and the audience, it was much more interactive than a lot of conferences. So
Yeah,
I
well, and
really,
I mean, I'm completely biased because I was on stage, but like you had Dr. Mary Claire Haver, you had Lise Newsom, you had Dr. Vonda Wright, you had me. Like, these are people who know how to speak, right? And it's like, dude, now that once you've had that, when you go to other medical conferences or scientific conferences, if they're not keeping you like active and engaged, social media has wrecked bad speakers for us, you know? Like, to me, I'm
yeah, I
like,
think,
there's like all of the speakers like are telling you their why of like why they're passionate about this. And like everybody else is just like being lifted up to be like, we can all do this. And that was my takeaway is like everybody was like in it for the right reason.
yeah, I think that's such a good point. And I hadn't actually thought of it like that, because I realize when you go with like an event like that, you hear what people are saying because they know how to speak. Whereas so much of our medical education is delivered or has been delivered in this dry, flat way, no humor. So you're not open. So as soon as you've engaged your audience, you've brought them in, as you say, you've told them your why, and there's some humor, there's some, compassion, there's some real, like human energy in it, then everybody opens up and they can listen and learn. And you remind, I think really all of those lectures, I don't want to call them lectures, they were, I don't know, manifestos, but
Yeah, yeah. I'm
they
like
really,
storytelling manifestos.
so like people really, that's why we do medicine or why we take care of patients, is to make them feel better and to live better lives. It's not, that's why we do it. So I think that's really, it's a reminder of, yeah, why we're in our profession. It's
It's
not
very
just,
different than being like, I mean, it's good to have guidelines. I don't get me wrong.
mm,
But like if you're sitting there just going through this is what the current guidelines are, you lose perspective of like what are we actually trying to do? We're trying to help people live productive, fruitful, healthy lives. I mean, I
and it's
remember
like,
Dr.
it's like
Louise
they're
Newsom.
maps. They're
Yeah.
maps, aren't they? And you're going to miss all of the amazing stuff that's off to the side or on new routes. This is like, we know so little. We have to keep evolving. Like, there's so much we don't know.
Yeah, totally. I remember Dr. Louise Newsom on stage and she was telling a story about a woman and her talk was like the evolution of this woman trying to get care. And like at some point I was like, oh God, I see where this story's going and it's not going to end well. And she actually told an absolutely heartbreaking story about a woman not being treated optimally for menopause and ending up losing her life over it. And it's like, if that didn't hook every single person in there to be like, I've got to watch out for these women and help them because it can be dire.
Mm.
I was like, I think I had tears in the back row.
Yeah, no, I think and that is really tragic. I have to say, I think I'm really lucky that I haven't lost any patients. I look, because I've been in the same general practice now for 12 years, I see the patients that I missed, in the first 7 years of that job. And I have got a patient who did try and take her life. Thankfully, she wasn't successful, and it was a menopausal depression. She's living her best life on HRT. So I think it's terrifying, to look back, and a lot of us have a lot of guilt. I know women that probably, although they haven't died, they lost. I have several patients who lost years of their lives, and I put them on hormone therapy, and within a few months they were back to themselves as much as they can be, because there's obviously a lot happens when you have 6 to 10 years of having a poorly treated psychiatric illness. It's actually a hormonal psychiatric illness. So I think there are so many women out there where nobody has thought about hormones as part of their treatment, and it can be, I've never seen medicine that's so transformative.
Yeah, I mean, going back to like a woman getting brave enough to ask for testosterone and then the physician asking them, are you sexually active with a partner, and declining her hormone that her ovaries naturally make because she doesn't have a partner. Like, it reeks so badly of, I won't give you a checking account or a mortgage because it's the 1950s because you don't have a man involved in your life. Like, it reeks of that, and it really bothers me.
Yeah, I think you couldn't get a mortgage in Northern Ireland until the 80s without a husband, actually.
Yeah.
It's horrific.
Credit card in America was 80s.
Just shocking. Like, do we
Business
still
woman,
have
right?
that in medicine where we
Right.
are?
We still have that in medicine. Like, you can't get this without a man. It's absolutely insane. My mom, and this is public, it was on my podcast. My mom, when she was a younger woman, she was married and declined birth control because the physician knew her last name and that the family was Catholic.
Awesome. Yeah,
Right.
we're
So,
not.
and it's like,
We haven't. We have. Like, what is this? Not 2025.
right, exactly. I'm like, that was the late 70s. And now we're like, that's ridiculous. And it's like, no, we're still doing that. We're still doing that with hormones our ovaries make. We're not letting a woman replace them unless she has a partner in her life.
But what's
That's why,
frustrating with testosterone, though, I actually saw a letter this week of a woman who'd had her ovaries removed, but I think before the time of natural menopause, and so it's quite an old letter. And she was sent home with a testosterone pellet, back. So this would have been in the 90s. So in Australia, and I don't know whether it was similar in the States, but a lot of gynecologists, when they did remove ovaries, sent their patients home with estrogen and testosterone implants. They knew. But this knowledge is
like,
not new.
we lost the medicine. I know, that's what I always joke about. People are like, I don't know about you. You will just want everybody on hormones. And I'm like, listen, in America, 5% of women are on hormones. In the 1990s, 40% of women were on hormones. Like, I'm just trying to get back to the 90s on that one.
Yeah, totally. I always say it was a great decade for music and it was a great decade for hormones. I'm sure the two are
It
connected.
was also a great decade for relative world peace.
Well, there
I
you
always
go.
joke, the biggest political problem in America in the 1990s was a blue dress and a blowjob.
Yeah.
If
Okay.
anybody remembers the Clinton era.
Yes, absolutely. Yeah, and look where we are
that
now.
that was the biggest to do then. Let's shift gears and talk about mast cells, because I need to be educated on mast cells, which means everybody else needs to be educated on mast cells. So tell me about your CFS and how you kind of got into this.
So this is recent. So this is really like the epiphany that has followed hormones. And
Yeah.
it is partly...
This is the next layer of onion peeling, my friends.
Yeah, it is. I'm just loving, and I just love the curiosity that I've found in my job again. And that's, I just say to anybody who's in medicine or looking after, just stay curious, because there is so much cool. There's so much cool stuff out there. So yeah, so mast cells is partly your fault. It was a podcast, I'm pretty sure, that you did with one of the Dr. Goldsteins, and he was
okay, yeah, my podcast with Andrew Goldstein.
Yeah, and he was talking about pelvic pain and vestibular pain and vulvodynia, and how some of those women were hypermobile. And it was the hypermobile bit that I went, oh, and I'm not sure if he mentioned mast cells at that point. I can't remember.
He might have. He was doing work and researching it at that time. So I would think he did. But that's probably a year ago on the podcast now, at least.
Yeah, so that was sort of there. And then I was chatting to... which doesn't mind, my hairdresser, who's hypermobile. And I was going, I think this is part of your menopause thing, that you're hypermobile. And there's something there with hypermobility and linking to other conditions. And I've just slowly been working my way through mainly podcasts. And then somebody in the menopause group, Samina Raymond, linked to, is it Samina, Gyno Girl? Is she Gyno Girl?
Yep, Gyno Girls.
Yeah, yeah. So she did a brilliant podcast with Dr. Tanya Dempsey, who I think is one of the world's gurus on mast cells. And since then, I've just working my way through all of these podcasts. So mast cells are one of our immune cells, and they exist in every tissue in our body. And they're really like our first line of defense to invaders. So they should be there trying to fight off viruses and bacteria, and they also react to toxins and probably react to toxic people. So they're there. And if you think of like scratching your skin, it gets itchy, but we've got them in our brain, we've got them in our gut, we've got them in our uterus, we've got them in our limbs. So there's a crossover between hypermobility, mast cells overacting, trauma in early life. And then, so I have this group of patients who have locked out, and I say that heavily sarcastically, in terms of they've got a history of PMDD, probably ADHD, they've got endometriosis or adenomyosis, or at least really heavy periods, they've got allergies, and then they hit perimenopause and it is a train wreck. So they're happy with my new diagnosis, which is CFS, which is clusterfuck syndrome, and that is literally... It is. It's
I'm just going to pause
wreck.
and say that in an American accent, because I don't want anybody to not hear what CFS stands for, which you've created, clusterfuck syndrome. Okay.
So
Proceed.
I mean, so CFS would traditionally been chronic fatigue syndrome, and actually a lot of those women would have been diagnosed or are diagnosed with chronic fatigue syndrome. And it's really where you're everything. So you've got hormonal chaos of perimenopause, and that is another big, has another big sort of dysregulating effect on this immune system that is already hyper vigilant, a nervous system that is hyper vigilant. So you hit perimenopause and you get the brain fog, you're starting to get allergies, itchy skin. You're developing autoimmune disease. We're getting our Hashimoto's, thyroid issues. We're getting women developing inflammatory bowel disease like Crohn's. And in the mast cells in the brain and the nervous system, when the hormones go off, that really can cause some quite significant mood changes. And I do wonder if the women that really struggle in perimenopause have got a lot of this mast cell activation going on. And a lot of them were ballerinas and gymnasts in their childhood. So the hypermobility is a big marker. So really interesting. So it's a whole other area of medicine where you've got doctors pushing the boundaries, talking to each other from different specialties, cardiology, psychiatry, immunology, going, hang on a second, there's something here. And it largely affects women. So I think it's like it's the mast cell posse version of the menopause, and another really exciting area of female health that can help us understand what's going on.
So is it a clinical diagnosis? Are you running tests to check for inflammation or mast cell activation? If there's a physician who's listening who's like, how do I even know if this is happening? Like what advice would you say for like picking up on these people? And then we'll go into like treatment options.
So I think to pick it up, you really, again, like menopause, you need to be listening to symptoms, and there are symptom score sheets. I don't think there's an agreed symptom score sheet for mast cell activation. There's mast cell activation syndrome as well, but a lot of people probably don't meet the full criteria. And the only easily accessible blood test that we would have would be a blood called tryptase, but it requires special conditions to take it, and it's not always positively positive in a certain percentage of people. So there are people in the States who know far much more. Like, I'm really on the beginning of this journey, so I'm not setting myself up in any way as somebody that knows much about it. It's just I'm
Next
starting
year's
to
Sydney
explore
Opera
it.
House will be mast
Yeah.
cell activation syndrome because you'll be the Australian expert by then.
I'm certainly interested. There's some great people in Australia already who've done quite a lot of work on this and who've connected to Americans. So the blood tests, again, are not that useful, just like perimenopause. A lot of the chemicals that are probably changing are not easily accessible, and they do, and these are things that are rapidly changing in your bloodstream and in your urine, so probably do require, sort of these longer tests and, really understanding. And I think it's at the minute in Australia, we don't have easy access to testing. I think in the States, you've got quite a lot of mast cell experts who know what they're on.
So you have a woman, you're like, maybe we've got some mast cell stuff going on here. What do you advise her to do as far as like lifestyle changes to try to mellow this out? And then what can we try as far as like immunomodulators, anti-inflammatory? What's the role of hormones? How do you start to try to help these people?
So again, a lot of it isn't rocket science. It's very much what we would say to our perimenopause and menopause patients is always going back to those beautiful pillars of health. So you want to eat a real food diet. So probably the rise of ultra processed foods is one of the reasons why we are seeing so many more people with allergies and possibly ADHD.
Because we're putting fake stuff in and our body's reacting to it. And then it builds up to a point over time that it's going to start looking like irritable bowel syndrome or arthritis or gut issues, skin issues. Yeah, is that the
Yeah,
logic?
exactly. Yeah, so I would say like ultra processed food is another, like, it's another toxin. So it's just, and over time your body's like, that's not what I want to eat, so it's reacting. So ultra processed food. So trying to get back to real food diet for people who are mast cell activated is a good idea to look at a low histamine diet, because once you're on the real foods, there probably are foods that are more triggering than others. There's things like avocados, kiwis, tomatoes, and leftovers, reheated leftovers for all of us who work in busy lives who like to reheat last
What's
night's
the
dinner
problem
for
with
lunch.
reheating food?
It really increases the histamine content of food.
Really?
Yeah. So so that's an
Whoa,
interesting one.
this sucks.
Yeah.
Are you telling me that we have to create fresh food every day? Like, that's a huge burden on people.
Yeah. You could have a salad
Yeah, you're like, sorry.
and
Sorry,
and
that's what
some
we did for all of evolution, Kelly. Okay, got it.
yeah. Yeah, yeah. So we didn't have fridges or freezers or microwaves. So a lot of it is just going back to basics, and you need to have a good you need to have a good night's sleep. Again, not rocket science. You need to move around. So sitting still is not good for you because your muscle obviously produces a lot of anti-inflammatory chemicals. So weightlifting, and Tanya Dempsey, I didn't realize, is a professional. I don't know if she's a professional weightlifter, but she's certainly a serious weightlifter.
Is she?
Yeah, she was nearly on the cover of Women's Fitness.
Your arms show off that you're a serious weightlifter. Sorry,
Well, I lift me.
only podcast people. Carrie's got envy. This woman wears tank tops proudly.
Yeah, it's the only
Tank tops
good
look
bit of me
very good on
left.
her. What's that?
So it's the only good bit of me left.
Your arms.
It's like, it's just arms. The rest of me is like a blob.
So what about like antihistamines? People talk about Benadryl, which like Benadryl's like a bad thing to do, but now people are like, no, Benadryl because it's antihistamine. What are people doing in addition to kind of tone down the mast cell activation?
So one other really important thing in terms that's not drug is like looking at heart rate variability training, breath work, breathing through your nose. So these are things that are, again, excellent for perimenopause and menopause. So nasal breathing and controlled breathing is a way of controlling your nervous system, which is a big part of mast cell. So really underused, breathe through your nose. So drug-wise, you can use antihistamines, and then we've got two types of antihistamines. We've got H1 blockers and we've got H2 blockers. So H1 blockers are the things, I don't know what you can get over the counter in the States, but drugs like loratadine or fexofenadine. So these are our traditional antihistamines people would use for hay fever or an itch. So you can try
like
those.
the
And
seasonal allergy meds.
Yeah, exactly.
Okay.
So you can buy, I presume you can buy those over the counter. So you would try one at a time. So you just do one and maybe try it for a week and see if it makes a difference. And if it makes a difference, then you could add on what's called an H2 blocker. And those traditionally would be ones that we use to suppress acid secretion, like famotidine. I can't remember what famotadine's called in the States. Pepsid? Yeah, it's Pepsid. So then you can add that on top. And the combination of those two antihistamines can make a big difference for people. And then you can add in some supplements. So vitamin C, which is obviously just supporting that real food diet. Magnesium can help people, making sure your vitamin D is optimized. Again, these are all the things we do for perimenopause. And zinc, a lot of things are deplete in our soil because we overfarm. So again, these are all things we would have just got naturally. And there's specific supplements that seem to act like mast cell stabilizers. There's luteolin and quercetin, which again, people can find. I think luteolin particularly people find really helpful, but you have to
Is that a
find the right
supplement?
dose. And that's a supplement, yeah,
It's
so
a
you can
supplement.
buy that.
Okay.
Yeah.
Do you
So
have
yes, so really,
like is there a patient story that comes to mind that you've had success with as far as like catching the mast cells and having their quality of life be better now?
yeah. So I've got some young patients who really come with all the things. And so they've got PMDD, which is, I suppose, an early marker of that you're going to have a bad perimenopause, urticaria and heavy periods. And starting them on the H1 blocker, I've used fexofenadine and then adding in famotidine on top. And suddenly their mood is better and calmer across the month. And I do use hormones as well for PMDD, but it's just not enough. So hormones are part of the package, but adding in the antihistamine as well has been a game changer. Urticaria is gone, that itchy skin, just feeling uncomfortable in yourself, and the gut symptoms will settle as well.
I mean, I
So
think the big thing for
exciting.
people to hear, and I just finished Dr. Elizabeth Coleman's It's All in Her Head book, so I'm like acutely sensitive to this right now, but that these women are labeled as crazy because they've got everything wrong with them. The tests all come back, air quotes normal. And we're like, dude, they're just complaining of everything. They're just like complaining people. And to be like, I listened to a podcast. I think it's like the Mast Cell podcast or something like that. That's one of the big ones?
Yeah, mast cell matters, yeah.
Mast Cell Matters. I was listening to an episode with the expert and I'm like, what if this is not all in her head? These are like literally inflammatory cells that are creating all of this. And it's just this like, what we said is like, you got to stay curious and not just assume. And again, for anybody who is under a rock and hasn't heard of Dr. Elizabeth Coleman's book, All in Her Head, read it. It basically says like, we've got to be real careful that we're not gaslighting women because we have such a strong culture of saying biologic things are psychological. Like we have centuries of historical context that's what we do to women. And so for this is like, oh my God, are we unroofing a biological reason for yet another thing? We are just saying women are crazy or overreactive or super sensitive, or, how we're dismissing this and be like, no, this could be like a dysregulated nervous system inflammatory issue.
Yeah, and we know that. So we know that people who have these adverse childhood events have a much higher incidence of chronic disease in later life. So this is what connects those things, that early life trauma in a genetically vulnerable person. And trauma, as I said, can be so many different things. But we've activated a nervous system, we've activated an immune system to be on high alert all the time, and that chronic low grade inflammation drives disease, it drives cancer, it drives obesity, drives a lot of mental health. So
It's like
women
it's
have
like the how behind the
exactly.
knowing that we already have.
Yeah, so it really makes sense. And we need to be intervening so much earlier. These teenage girls that I see I think that this is really increased, and it's increased post COVID for probably a multitude of reasons. But we need to be looking after this population, our younger population, so that they don't have 30 years until, finally it's a train wreck at perimenopause. I think there's things that we could do, and it is largely women. I think the hormones coming in at puberty are the first thing that sets this off. So that's why women are hugely overrepresented in this clusterfuck syndrome. Men are affected, but not in the same way. And endometriosis probably sits in this syndrome somewhere. So endometriosis is covered in mast cells, and this is something we think, and we do think endometriosis is on the rise as well.
Interesting. Very interesting. God, how it all like ties together of like, you heard Andrew Goldstein on my podcast. You got, I would, as a compliment, obsessed about this topic, and like the amount of women you're now helping in your town because of that. And like how this just continues. Like, that's just the coolest thing ever.
And I think that's the thing. That's just, if you're not curious, are you ever going to ask the questions? So
Yeah.
yeah, I think
I mean,
I think we need to
I think in current medical is like, you need the right code, you need the right diagnosis, you need to write the order the correct test. Like, none of that is curiosity.
I think we traumatize. I think we traumatize our doctors in training. It's hard, and I think when you're traumatized, your curiosity dies. And I think it took a long time for mine to come back and go, actually, I know enough that I can start to look outside of my little box.
Yeah. And then like learning's fun again. Like, we went to medical school because we like to learn, and like my story is like 7 years in, I was bored at the 7-year itch, being like, what the F am I doing? I'm saying the same thing over and over. What did I do all this training for? Like, I know the day that my curiosity came back, right? Like, I had a patient that brought my curiosity back. And now that's just like, put me on the Sydney Opera House stage, apparently.
Yeah, that's it. That's where
Just
curiosity
like
gets you.
that. That's what happens. One more question on the Mast syndrome. I was listening to the podcast, and she was talking about women who are on SSRIs, because we know in America, it's like 40% of midlife women are on SSRIs now, being medicated for things that SSRIs aren't the best things for, like menopause. But she says women who have trouble getting off of the SSRIs, they just can't get off of these things. And they have to do like the slow wean. She's like, consider mast cell activation syndrome, because the SSRIs are actually like tamping down the mast cells. And every time they try to get off the SSRIs, they have a flare. And that's why they react so poorly to trying to get off these meds. Talk to me about that.
Yeah, so that is, again, and I've got a couple of patients in that group who had the worst menopause ever and were missed and went on to antidepressants, and it's taking years to come off. And it is, trying to use the antihistamines alongside that is another way of doing it. But ultimately, I have found that you just have to do this extremely slow taper, and our drugs are not made, antidepressant drugs are not made to be tapered. I think maybe Sweden has got a tapering, you can get tapering drugs, but we have got a program out of the University of Queensland in Australia, which has tapering protocols for multiple antidepressants and telling you how to do it with your patient, because so many patients will, you'll tell them just to go to alternate days and then stop. And people who are mast cell activated, because the SSRI seems to have an antihistamine effect, they just can't do it. So we have to go really, really slowly and supplement them with other things that can help their mast cells, but very difficult.
I love that. I mean, I remember where I was walking, listening to this podcast episode and being like, what? And realizing like how much we don't know. but super exciting for people to start thinking
Yeah.
about stuff like this. Especially when we're like, SSRIs are dependently associated with bone fracture. Like, I really think we're at the beginning of being brave enough to talk about how do we get 40% of the population maybe not on these drugs. Not to say everybody should stop them, but we know some people were put on them for reasons that didn't require SSRIs and now they can't get off.
Yeah, I think we just really need to be putting, instead of just putting people on an SSRI, and as you say, absolutely needed for some people, but we need to look at all of the tools in the toolkit like we do for perimenopause, hormones, lifestyle, nutrition, supplements. I think all of these things are so key. Medicine has trained a lot of us to look at one specific drug for each distressing symptom or each disability, when really we need to look at the person as a whole person, look at the root cause, and look at the things that are largely common sense and very safe, and then start to build out from that. That takes time, and I think your system and our system doesn't encourage or doesn't support physician time with the patient. It's hard to do that good medicine in 10 minutes.
I would say damn near impossible. So the people that do it, we see you. But there is something to being able to spend more time with people. Like, it's truly like the relationship itself is healing, and we've taken that away as well. One more thing I want to talk about before we wrap it up. When I was in Australia, it seemed like everybody was on vaginal DHEA. You guys have intrarosa or progesterone just like we do, but unlike America, you guys are actually on this product. And so, like, at some point I was like, why is everybody on vaginal DHEA here? And they're like, because it's only $40 a month here. In America, at best, it's $80 a month.
Yeah, so I mean, that's a good thing. A lot of our drugs, you're not supposed to tell anybody, because Trump, I think, is having a wee paddy at the minute about how much you guys pay for drugs. And Australia, I think, has been very effective at negotiating good price points with pharmaceutical companies. So yeah, we do have DHEA. I think you were lucky who you met, to be honest.
I had a
prescribe a lot of
curated
DHEA.
group of women who had access. That's
Yeah.
who I was talking to. Yeah, fair enough.
Yeah, you got the lucky ones. We know in Australia our prescribing of vaginal hormones is abominable. So it's still about less than 10% of postmenopausal women are on vaginal hormones. But counter, it's probably less than 1% are on vaginal DHEA, which is intrarosa in Australia. And that's my other thing that I could pitch if any Australian clinicians are listening. I've just launched my survey into clinicians' attitudes to GSM and prescribing. So I want to use this as it's a research project that I'm doing with the University of New South Wales to see why doctors don't ask about GSM and why we aren't prescribing. Hopefully we will get
Send
more
me
women
those
on
results
vaginas.
when you have them. I'm guessing it's time, knowledge, and like the stigma of sex.
Yeah. Yeah.
But
So
maybe
let's
it's
see if they
something else and
realize
we'll
that.
learn something.
Yeah. But it's really just to get the conversation.
Yeah, get this conversation going. Yeah, absolutely. Anything else we missed? I love
Well,
you. I think the world of you.
testosterone for women, we deserve it. We deserve
Testosterone
to be
for
able to
women.
try it.
Just try it. I know. That's the thing. It's like, one more plug on dementia. Do you guys have PBS approved dementia medications? Do you have what we have?
Yeah.
Okay.
Well, I can't remember if the new one's just been a TGA approved, the monoclonal antibody, the one that causes brain bleeds.
Yeah, the brain bleed one. Yeah, perfect. I mean, my big plug is especially in Australia, because I'm like, if you guys, your number one killer now is not shark bites or tarantula bites, it's dementia. We have there's no cure. The treatments are expensive and crappy. Side effects include brain hemorrhage. Like, the lack of curiosity of what happens. That's the other thing people don't know. On that tragic Tuesday that you're diagnosed with dementia, this started 20 years prior, right? And like the tragic lack of curiosity of like, we don't need a 20-year randomized controlled placebo-controlled trial that costs $1 billion. We don't have time. We do not have time for that. You're dying. That's your number one killer now. Why aren't we saying, you know what? We don't know fully, but we know these hormones are cheap. And we know that they will help some things. They might prevent dementia, and we've got nothing else. Why aren't we using them?
100%. And we know that osteoporosis and dementia are connected. So if you've got osteoporosis, you're much more likely to have dementia. We know that, and I know you can't say that because HRT prevents osteoporosis, it's going to prevent dementia, but you have to wonder. Anything that supports mitochondrial function, which estrogen does, our mitochondria are covered in estrogen receptors, probably progesterone receptors and testosterone receptors too. Mitochondrial health is the key to longevity. It's the key to health span. It makes basic scientific sense that supporting hormones and all the other things, like none of us as people suggest that menopause doctors just say take HRT and you'll be fine. Take your hormones, lift your weights, keep moving, eat well, sleep enough. All of those things support mitochondrial health. And that's what's dying, or what has been dying, when dementia hits 20
I mean,
years
I like
later.
glial cells. Testosterone specifically supports glial cells, which are the supporting cells to the neurons. And so, like, we have all this basic science, and I'm to the point of, like, the basic science researchers have to be, like, rolling over in their beds being like, "What the F are we doing all this basic science for if you're not gonna use it in clinical practice?" Of, like, every piece of basic science says estrogen and testosterone protect nerves.
Yeah, we've got all the data. If you've got more hot flushes, you're going to have more what we call white matter changes on your brain scan, and that's because of loss of myelin. As you said, like the estrogen, testosterone, progesterone all stimulate the little oligodendrocytes, which are the brain cells that produce myelin. So we've got, as you say, the basic science is there. There's no other sort of drug or medicine that can stimulate nerve growth. Exercise, yes, does it as well, but in terms of drugs, we don't have another drug that will build brain, build bone properly, build muscle. You know, it's just obvious, really.
I know, it's to quote our very good, lovely friend, Dr. Lisa Newsom, "It's just so obvious, Kelly." She's like, it's just so obvious, isn't it? It's just so
Yeah.
obvious." Okay, so when are you coming to America? Are you coming to Ishwish 2026?
Yes, I'd love to. I'm just slightly scared. Will I have to clear my social media account to get into the country? I would desperately want to come to Ipswich.
Oh, I mean, I live close to the Canadian border, and I'm like, the Canadians are very afraid now, and they're like, "Kelly, can you promise me that I won't have to pledge allegiance to Trump when I cross the border?" And I'm like, first of all, that sounds crazy, but again, I'm a child of the 90s, and our biggest problem was like a blue dress and blowjobs. So like, I can't imagine this is going on, but I'm like, I can't promise you that. Nobody put me in charge of the border.
I'll come in through Canada. My dad lives in Vancouver, so that's
There
just
you
over
go.
the
We want you
border.
coming through Canada. We'll travel to California together.
Yeah, sounds good. Yes, road
Yeah,
trip.
it'll be good. Everybody sign the petition for Australia to get testosterone on the PBS. We must support this company because it's now in, this product, South Africa, New Zealand, UK, Australia. It's in 4 countries now. We desperately need it in America, and we need to help out the Australian women so that we decrease the stigma to testosterone. You don't need to be partnered to get a prescription for testosterone. It's insane. And check out Healthy Hormones if you're a clinician or a layperson for menopause and perimenopause support.
Yeah, awesome. Please do. We want you on
Thanks for
there.
coming
We
on my
need to learn so
podcast.
much. Thank you for
Pleasure to
having
have
me.
you.
It's so
Okay,
nice to chat.
nice to chat. Until next time.